Hello, thank you for joining us today. This is the AGA webinar on the IBS treatment guideline. I'm Chang from the David Geffen School of Medicine at UCLA and lead author of the technical review. And I'm joined by Shahnaz Sultan, MD, who's a University of Minnesota, Minneapolis VA Health System, and she's an author of the treatment guideline as well as the treatment review and the technical review and also the clinical guideline. So during this webinar, we'll review the objectives of the technical review, our findings, and the resulting guidelines. And all questions will be answered at the end of the webinar. To ask a question, just type your question in the question pane. So we can go to the first slide. I just want to give a little bit of introduction on irritable bowel syndrome, which we term IBS, and I'm sure you're all familiar with. It's a functional GI disorder that's characterized by chronic or recurrent abdominal pain, and it's associated with altered bowel habits where patients will have diarrhea, constipation, or they can have both mixed, constipation and diarrhea. Functional is not a great term, but it's used when there's no structural or biochemical abnormality to explain the symptoms. It has a worldwide prevalence. It's about 11% in the United States. It's more common in women, and also in younger individuals. There's a significant impact on the health-related quality of life that's been shown in multiple studies, and it's worse than gastroesophageal reflux disease, comparable to end-stage renal disease and diabetes. There's also a significant economic and healthcare burden associated with IBS. So this is the Rome-3 diagnostic criteria that we use to diagnose IBS currently. We don't have a diagnostic biomarker, so we use symptom-based criteria. And the criteria is based on evidence and also expert consensus. But basically, the patients have to have at least 3 days per month of recurrent abdominal pain and or discomfort in the past 3 months because we want to make sure they have active symptoms. But the pain has to be associated with 2 of the 3 following. Improvement with a bowel movement. The onset of the pain is associated with a change in the stool frequency, so they go more often or less often. And the onset of the pain is associated with a change in stool form, whether the stool will be hard, lumpy stools or loose, watery stools. And then we want to make sure that the patients had symptoms for at least 6 months ago because we don't want to confuse it with a more acute illness. Next slide. When we look at IBS subtypes, we basically have 3 main subtypes, and that's IBS with constipation, which we call IBS-C, IBS with diarrhea, or IBS-D, and then we have IBS with mixed pattern. And this is all based on stool form, and there's several studies that have supported this. It's better to look at stool form than stool frequency, that predicts your bowel habit subtype. So this is a Bristol Stool Form Scale, which I don't know if you're familiar with, but it's multiple pictures from type 1 to type 7 with the text. And this correlates with how fast stool moves through your GI tract. So the type 1 and 2 stools are the constipation stools, type 6 and 7 are the diarrhea stools. So if at least 25% of your bowel movements are hard lumpy and less than 25% are the loose watery, you have IBS with constipation. And then just direct opposite, if you have greater than 25% of the time you have loose watery stools and less than 25% of the time you have hard lumpy stools, you have IBS with diarrhea. And the mixed population basically has both extremes. So we published 2 papers just recently in gastroenterology, and the one is the AGA technical review on IBS therapy, and you're going to hear much more about it from both Dr. Sultan and myself. And this review really provides evidence-based information to guide clinicians and patients the most appropriate therapy. And then the next publication, and they're side by side, this is the AGA guideline on IBS therapy. Dr. Weinberg, Smalley, Heidelberg, and also Sultan are authors on this guideline, and reviews the official recommendations of the AGA on the use of pharmacologic agents for the treatment of IBS. So I just wanted to remind everyone that we only looked at pharmacologic agents, even though there are other treatment interventions that you can consider using in IBS. And Shahnaz, you want to explain this?
Hi, this is Shahnaz. So I'm going to talk about the objectives. This technical review was conducted to inform the AGA guidelines for the management of irritable bowel syndrome. And we started off by using the PICO format, which frames a clinical question by defining a specific patient population, P, intervention I, comparator C, and outcomes O. Using the PICO format, we outlined 9 questions. We then conducted a comprehensive systematic review of the literature using a number of different databases for each PICO. We included studies of adults 18 years of age and older and limited our search to randomized controlled trials, existing meta-analyses, systematic reviews, and health technology assessments published from 1995 onwards. Using the GRADE framework, we then rated the quality of evidence for each outcome. Next slide. So within GRADE, the quality of evidence is defined as the extent to which our confidence in an estimate of the treatment effect is adequate to support a particular recommendation. So we usually think of quality of evidence on a continuum, but within GRADE, it's categorized into 4 discrete categories: high, moderate, low, and very low. And the determinants of quality include study design, methodological limitations such as lack of blinding, allocation concealment, or high loss to follow-up, inconsistency or heterogeneity, imprecision, indirectness, and suspected publication bias. And this is assessed for each outcome. The overall quality of evidence is then based on quality across all critical outcomes. And finally, an evidence profile or summary of findings table is produced. This is a visual representation of the quality of evidence and the pooled effect estimates for each outcome, and it represents the totality of evidence for a specific PICO. Next slide. So as Lynn alluded to, this technical review focused on IBS pharmacotherapies, and we looked at 3 treatment groups. We looked at, for IBS-C, we looked at linaclotide, lubiprostone, and PEG laxatives. For IBS-D, we looked at rifaximin, alosetron, and loperamide. And then we looked at tricyclic antidepressants, SSRIs, and antispasmodics for global IBS symptoms. We focused our technical review and our comprehensive systematic review on studies that included adults and where the comparators were mostly placebo. Next slide. So these are the outcomes that we focused on within GRADE. As I mentioned, quality of evidence is assessed on an outcome basis, and there's an emphasis on looking at not only beneficial outcomes but also harm outcomes. And so we defined these outcomes a priori before we started our systematic search and looked at FDA responder endpoint, which Lynn is going to talk about in a little bit more detail, as well as global relief. We then also looked at individual symptom relief. So we focused on abdominal pain, complete spontaneous bowel movement, and spontaneous bowel movement for IBS-C patients. And for IBS-D, we also focused on bloating and stool consistency and urgency. And then we looked at health-related quality of life as one of the other beneficial outcomes. For harm outcomes, we looked at adverse events that led to treatment discontinuation. And for specific pharmacotherapies, we actually outlined specific harm outcomes that we know are associated with that drug. For example, with Alosetron, we looked at ischemic colitis. Next slide.
So there's been an evolution with IBS clinical trials with the different types of endpoints, and the FDA published a guidance a few years ago stating that there wasn't a valid, reliable patient-reported outcome measure for IBS. And so they came up with interim composite endpoints that we now use in clinical trials, although there are many efforts being made to develop a valid and reliable primary endpoint for IBS. But currently we're using the FDA's guidance on the primary endpoint. Because IBS is defined as abdominal pain that's improved with defecation and altered bowel habits, the FDA recommends evaluation of a primary endpoint that includes 2 major symptoms: abdominal pain and defecation. Now, these entry criteria and responder definitions are different for IBS with constipation and IBS with diarrhea. But we're going to review the pharmacologic agents for IBS-C right now. So I just wanted to go over for the studies that measured FDA responder rates, this is the interim endpoint. So to enter a clinical trial with you having IBS with constipation, you had to have a certain pain severity level. They used a well-known numeric rating scale of 0 to 10 for your worst pain in the past 24 hours. And you had to have a weekly average of at least 3 on this 11-point numeric rating scale to enter a trial. Your stool frequency, you had to have less than 3 complete spontaneous bowel movements per week. That's been often used in constipation studies. So not only do you spontaneously go to the bathroom less than 3 times a week, they cannot feel like it's a complete evacuation. And then they also looked at a daily symptom diary and a weekly global assessment. Now, to qualify as a responder, the patients had to have improvement They were a weekly responder if they had improvement in both pain severity and stool frequency for at least 50% of the weeks. And to be a pain severity responder, you had to have an improvement of at least 30%, a reduction of 30% on this numeric rating scale for the worst abdominal pain. And for stool frequency responder definition, you had to have an increase of at least one complete spontaneous bowel movement per week compared to baseline. So this is just a schematic of the first two agents that we're going to talk about for IBS-C. It's linaclotide, which you see on the right, and lubiprostone on the left. Both of them work on the chloride channels in the gut lumen, both in the small bowel and in the colon, on the epithelial lining. So for linaclotide, it's a guanylate cyclase C agonist, so it acts on that GCC receptor, and it increases cyclic GMP, and this will now increase on the CFTR, which is the cystic fibrosis transmembrane regulator, which is the primary chloride channel in the gut. It will help secrete chloride and water and bicarbonate, and that will help move stool through the lumen of the bowel. Lubiprostone works on a different chloride channel. It works on the CLC2, which is the secondary channel, but what it does is it increases chloride secretion very similarly to linaclotide. They're both peripherally acting agents, and they have been studied in clinical trials both with IBS-C and chronic constipation.
So this is an evidence profile. Because this is the first time that you may be looking at an evidence profile, I'm going to give you a brief overview. This evidence profile is for the question, for our first PICO question, should linaclotide be used in IBS-C? And if you look at this very busy table, you'll see that there's two kind of main sections. The left-hand side of the table outlines the quality assessment, and the right-hand side illustrates the pooled relative and absolute effects. And each row of the evidence profile represents a patient-important outcome. For this evidence profile, we had 6 a priori identified outcomes. The two boxed in red were our critical outcomes, that is critical for decision-making, and the row in yellow is our harm outcome, which in this case was adverse events leading to treatment discontinuation. For each outcome, we identify the number of studies and the number of patients that inform that outcome, and then we illustrate the quality of the evidence for each outcome and the pooled effect estimate. So this is kind of an overview of an evidence profile. For each of the pharmacotherapies, we created an evidence profile that looked at the totality of evidence for that therapy. And for the purposes of this webinar, I'm not going to go into too many details about how we came up with the quality ratings or our pooled effect estimates, but I will give you a summary of the overall quality of evidence and also where we saw actual clinical or significant improvement in some of the outcomes that we considered for each of the pharmacotherapies. So next slide. Let's look at the evidence profile for linaclotide again. Next slide. Okay, so here we see that we focused on the two critical outcomes, and we looked at failure of symptom relief and failure of adequate global relief, and for each of those we saw a clinically meaningful improvement. And for diarrhea, we saw that there were patients that had 31 more events per 1,000 people treated who had diarrhea that led to treatment discontinuation. Next slide. And so overall, we found that there was clinically meaningful improvement in symptom relief, overall symptom relief using the FDA responder endpoint, and global relief. And we also saw improvement in abdominal pain, an increase in the number of complete spontaneous bowel movements, and improvement in health-related quality of life. Next slide. The overall quality of evidence across all critical outcomes for linaclotide was high. There were no serious methodological limitations and no issues with any of the quality domains that I had discussed earlier. No issues with inconsistency, indirectness, imprecision, or publication bias, which would have warranted downgrading of the quality of the evidence. Lynn is going to now talk a little bit about discussion.
Yeah, I just want to summarize a few of the points that were made in our discussion in the paper. Just something that this company actually determined in a publication in Neurogastroenterology Motility is this FDA responder definition really clinically meaningful? And they had different ways of measuring it, and they found that using this FDA endpoint was clinically meaningful in these IBS-C patients. And we know that relief of abdominal pain is really an important goal, because if you look at IBS patients, pain is the major predictor of symptom severity, health-related quality of life, and physician visits. So to relieve abdominal pain significantly and effectively is always a great goal in IBS patients. The other point I wanted to make in their clinical trials is that even though patients may have improvement in bowel habits earlier when they take the linaclotide, the maximal effect on abdominal pain can take up to 8 to 12 weeks. So to see that effect, you would have to leave your patients on the medication for a longer period of time in some of the patients. And again, diarrhea was really the most frequent side effect that we do see clinically, and we try to manage it by lowering the dose or changing the frequency. So for the guideline, linaclotide was given a strong recommendation to be used in patients with IBS-C with high quality evidence, and the AGA recommended using this medication over no drug treatment in IBS-C. Now, patients who have a high value on avoiding diarrhea and avoiding higher out-of-pocket expenses associated with linaclotide may prefer alternate treatments, but this medication did show a beneficial effect on combined GI symptom endpoints as well as global relief. The diarrhea led to treatment discontinuation in a small percentage of individuals, and the recommendation was made without taking resource use into account. However, patients' values and preferences regarding costs were acknowledged.
So now we're at our next evidence profile. In this evidence profile, we address the PICO question: should lubiprostone be used in patients with IBS-C? And again, you'll see that our outcomes are very similar to the outcomes that we had for linaclotide. Again, our two critical outcomes are highlighted in red boxes and our harm outcomes in yellow. And you'll see that there was, in absolute terms, 102 fewer failures of symptom relief and 63 fewer failures for adequate global relief. Next slide. And some increased adverse events leading to treatment discontinuation, 615 more per thousand. But overall, in summary, this meant that there was clinically meaningful improvement in overall symptom relief, again, using the FDA responder endpoint and in global relief. And then looking at the individual symptoms, we also found improvement in abdominal pain, increase in the number of complete spontaneous bowel movements, and also improvement in health-related quality of life. Next slide. So the overall quality of evidence across all critical outcomes for lubiprostone was considered moderate, however. And this is because the lower boundary of the 95% confidence interval suggested that the beneficial effect could actually be lower than the pooled effect that we had found. So it suggested that the beneficial effect could be as low as 4%. And this actually did not meet our threshold of a clinically meaningful improvement, which we predefined as a 10% improvement. So we actually rated down from high to moderate to reflect this uncertainty in the treatment effect.
Yeah, so we also wanted to state in our technical review that these clinical trials with lubiprostone predated the FDA composite endpoints, so they were never able to prospectively look at that. They looked at spontaneous bowel movement frequency rather than complete spontaneous bowel movement frequency. But we were fortunate to get a post hoc analysis to be able to assess some of the main outcomes that we wanted in this trial. And the overall quality of evidence across all critical outcomes for lubiprostone was moderate, as you heard before. What we found, though, that was not associated with significant benefit on spontaneous bowel movement frequency. More data on the improvement in the number of spontaneous bowel movements and abdominal pain is still needed. So the AGA suggests that lubiprostone was recommended over no drug treatment in patients with IBS-C with a conditional recommendation and moderate quality evidence. Patients who place a higher value on avoiding higher out-of-pocket expenses associated with lubiprostone may prefer alternate treatments. The beneficial effects on combined GI endpoint, the FDA responder definition, global relief and abdominal pain was apparent with a few adverse events, namely nausea, presumed variability in patients' values and preferences with respect to cost. Resource use was not explicitly taken into account. And my only other comment about the nausea is it's basically, if you want to use it in patients, it's recommended to take it with meals. That reduces the nausea, and men and older individuals had less nausea than younger women. So the next A pharmacologic agent is polyethylene glycol, we call PEG laxatives. This is osmotic laxative, and this just gives a schematic on how osmotic laxatives work, where they draw water in the lumen of the bowel. It loosens and softens the stool, increases fecal mass, and stimulates peristalsis. They can have some side effects like bloating, gas, borborygmi, diarrhea. Not so much with PEG, but with magnesium laxatives, you have to use them with caution in patients with significant heart and kidney disease, but that doesn't apply to PEG.
So this is the evidence profile looking at the body of evidence for PEG laxatives in patients with IBS-C. And you'll see here that we had our FDA responder endpoint as our critical outcome, and we found that there was actually no improvement in patients with IBS-C who took PEG laxatives, and the adverse effects were not reported in the studies that we had looked at. So overall, we found no clinically meaningful improvement in symptom relief using the FDA responder endpoint, and no clinically meaningful improvement in abdominal pain. Next slide. The overall quality of evidence across all critical outcomes for PEG laxatives, however, was low. There was basically one randomized control trial with serious methodological limitations, and again, because the boundaries of the 95% confidence interval suggested a possible benefit or harm, we rated down for imprecision to reflect this uncertainty in the treatment effect.
Yeah, so we didn't find any statistically significant or clinically meaningful improvements in abdominal pain or in the modified FDA responder endpoint that they used. Unfortunately, we weren't able to get responder rates for the spontaneous bowel movement frequency, even though they showed differences by the mean change. Next slide. So the question of should PEG laxatives be used in patients with IBS-C, the overall quality of evidence across all critical outcomes for PEG laxatives was low. I do want to make a note that this wasn't just polyethylene glycol by itself. It was polyethylene glycol with electrolytes, and that's used in some countries for chronic constipation. The efficacy of PEG has been studied more in chronic constipation as opposed to IBS with constipation. They've shown significant improvement in complete spontaneous bowel movements, but the responder rate could not be calculated, as I mentioned. PEG laxatives may be useful in patients with IBS-C for specific symptom relief for improving, for example, their bowel movement frequency or as an adjunctive treatment. So the conditional recommendation was made and with low quality evidence. Low quality evidence suggested no beneficial effects in global symptoms or abdominal pain. However, a large body of indirect evidence shows that laxatives are effective in increasing the frequency of bowel movements with few reported adverse events. Though resource use was not explicitly considered, cost of treatment is very low. So for the IBS-D, which we're going to move to, we have 3 pharmacologic agents, rifaximin, Alosetron, and Loperamide, and we'll review the mechanism of action for each one. Before we do that, I wanted to just mention the interim endpoints by the FDA for IBS with diarrhea. As I mentioned, it's a little bit different than the IBS-C. So they have still the composite endpoint of pain severity and bowel habit. The pain severity is exactly the same as IBS-C. You have to have a weekly average of worst pain in the past 24 hours of a score of at least 3 on an 11-point scale between 0 and 10. But they use stool consistency for IBS with diarrhea rather than stool frequency like they did for IBS with constipation. So the patients to enter a trial had to have at least 2 days per week with a bowel movement that was loose or watery, so that's type 6 or 7 on the Bristol Stool Form scale. They also looked at daily symptom diary and a weekly global assessment. For the responder definition, it was very similar to IBS-C with respect to pain severity. They had to have, do you have another slide? Yeah. They had to have at least a 30% reduction in their pain severity. For the stool consistency, they had to have at least a 50% reduction in the number of days with a diarrheal stool. They also you could also determine if a stool consistency responder was weekly or daily. So rifaximin, as you probably all know, is a non-absorbable antibiotic. It's derived from rifamycin, so it's really not systemically absorbed. It's just very, very little. It's delivered in high concentration in the GI tract, and that's why it's used for traveler's diarrhea. It inhibits RNA synthesis of target microorganism and has in vitro activity against gram-positive and gram-negative aerobic and anaerobic bacteria. If you look at side effects, what has been reported is flatulence, headache, and abdominal pain.
So this is looking at addressing the people question, should rifaximin be used in patients with IBS-D? This is the evidence profile looking at the totality of the evidence. And you'll see here that our outcomes are slightly different. In addition to symptom relief and added global relief, we also looked at bloating response. So overall, there were 95 fewer failures of symptom relief, 85 fewer failures of adequate global relief, and this, next slide, this meant that there was clinically meaningful improvement in overall symptom relief using that FDA responder endpoint and global relief. And we also saw that there was improvement in individual symptoms such as abdominal pain and bloating. The overall quality of evidence across all critical outcomes for rifaximin was deemed as moderate. So even though an overall benefit was seen, the lower boundary of the 95% confidence interval suggested that the beneficial effect was actually, or could be small, as low as only a 60% improvement. And again, this did not meet our threshold for clinically meaningful improvement, and so we rated down to reflect this uncertainty in the treatment effect.
So one of the issues in the prior clinical trials of rifaximin, where it's a 2-week treatment course, is that when they followed patients over time, the efficacy appeared to potentially diminish over time, and that's why new treatment trials were instituted to look at retreatment over time. The overall quality of evidence across all critical outcomes for rifaximin was moderate. There are previous meta-analyses that noted that older patients and women had higher responder rates, which I thought was interesting. And a recent clinical trial showed comparable improvement from the initial treatment with repeated treatment up to 2 times. And at present, rifaximin is not approved by the FDA for treatment of IBS with diarrhea, but it will potentially be looking through the retreatment trial data for possible approval in IBS with diarrhea. So should rifaximin be used in patients with IBS diarrhea? Well, the AGA gave it a conditional recommendation with moderate quality evidence and suggests using rifaximin over no drug treatment in patients with IBS with diarrhea. There's overall beneficial effects with little side effects. Resources were not taken into consideration, but notably the cost of the treatment may be high. So we're going to move to a serotonergic agent, and serotonin, as you know, is 5-HT, and most of serotonin is made in the gut. Some is made in the central nervous system, but of course that is important as well. In the gut, the serotonin mediates gastrointestinal function both in the enteric nervous system and through the brain-gut interactions, and affects motility, sensation, or what patients perceive as their symptoms, secretion. So in studies, they've shown that mechanical and chemical stimuli in the gut can lead to stimulus of these enterochromaffin cells and mast cells, and they release 5-HT or serotonin. After a meal, plasma 5-HT can increase, but you see it more in IBS than healthy individuals, and particularly in the IBS with diarrhea group. So when you have more 5-HT, it acts on 5-HT receptors, and it can stimulate motility and secretion. I think there's another bullet. Oh, there was one other thing I was going to say. For Alosetron, which we're going to talk about, this is specifically a 5-HT3 antagonist. So it blocks that one receptor, the 5-HT3, and by doing that, it slows motility and it decreases sensation. And that's why it was used in IBS with diarrhea.
So this is the evidence table for the question, should Alosetron be used in patients with IBS-D? And I wanted to point out again that our outcomes are slightly different here. So we looked at our outcome of adequate global relief response, and then we looked at individual symptoms such as abdominal pain, but we also tried to get information about urgency and stool consistency. And then finally for harm, because there is known harm that was associated with Alosetron, we specifically looked at ischemic colitis and the outcome of serious complications of constipation. So overall, we found that for global relief, there were actually 217 fewer failures. And in long-term studies looking at the use of Alosetron in select patient populations and specific doses, we found that the incidence of ischemic colitis and of serious complications of constipation was pretty low. It was 1.03 cases per 1,000 patient years for ischemic colitis and 0.25 cases per 1,000 patient years for serious complications of constipation. So this translated into clinically meaningful improvements in global relief. And we also found that there was clinically meaningful improvement in abdominal pain. The overall quality of evidence across all critical outcomes for Alosetron was considered moderate. So we rated down the quality of evidence because of serious inconsistency or heterogeneity, which may have partly been attributed to different doses of treatments used across the studies.
Yeah, so the treatment trials in IBS with diarrhea with Alosetron were mainly assessing the adequate relief of abdominal pain and discomfort. This is one of the older primary endpoints that we used in IBS. Adequate global relief, rather than just specifically looking at pain discomfort, was assessed in only 2 trials. The overall quality of evidence across the critical outcomes for Alosetron was moderate. It is important in clinical practice to carefully select the patients that should get treated with Alosetron because it is on a restricted use program that the physician has to sign up, and it means that the physician is aware of who to treat who to treat with Alosetron and understand the potential side effects. So Alosetron is the only FDA-approved treatment for use in women with severe IBS with diarrhea because of concerns of idiopathic non-dose-dependent ischemic colitis, as you heard, 1 out of 1,000 patient years. Alosetron was reintroduced only under a specific physician-based risk management program. That's been in effect for about 12 years at least. There was a recent post-marketing adjudication study that showed that the ischemic colitis was stable over time, but patients should be treated under this risk management program. So should Alosetron be used in patients with IBS-D? The AGA gave it a conditional recommendation with moderate quality evidence and suggested using Alosetron over no drug treatment in patients with IBS with diarrhea. Overall beneficial effects in global symptoms and abdominal pain with some downsides, while serious, observed in a very small sample of patients. Patient values and preferences were presumed to be variable, and cost was not taken into account. So now we're going to move to treatments that were being used in IBS, not specifically any particular bowel habit, and that includes 2 antidepressant classes, the tricyclic antidepressants, and selective serotonin reuptake inhibitors, SSRIs, and also antispasmodics. Okay, so first this is going to talk about the antidiarrheal agents, and this just shows a figure on how these opiates, which are these antidiarrheal agents like Loperamide, act and decrease diarrhea. So they suppress the excitability of the Secretomotor neurons, which typically release acetylcholine, but they block that, so there's secretion and motor function is decreased.
So this is looking at the body of evidence for Loperamide and its use in patients with IBS-D. Again, our critical outcome was adequate global relief response. And then we also looked at specifically abdominal pain response and urgency, stool consistency. Next slide. And we found that there was actually no improvement in our critical outcome, and our adverse events actually were not reported in these studies. So overall, there was no clinically meaningful improvement in global relief, but there was some clinically meaningful improvement in abdominal pain and stool consistency. The overall quality of evidence across all critical outcomes for Loperamide was deemed to be very low, and this is because of the fact that these were very small studies that were older, and there were serious methodological limitations in these randomized controlled trials, as well as issues with imprecision and publication bias.
Yeah, so again, these were 2 older, very small studies, not conducted in the same way that we do studies now. They're both in 1987, but this medication does have proven efficacy in reducing diarrhea. The overall quality of evidence across all critical outcomes for Loperamide was very low. We don't really know the optimal dose. There was some attempts in the past to try to determine how you would use Loperamide in IBS with diarrhea, but it can be viewed as a useful adjunct to other IBS-D therapies. Patients use it in different ways depending on how severe or frequent their symptoms are. So should Loperamide be used in patients with IBS-D? The AGA gave it a conditional recommendation, very low quality evidence. They suggested using Loperamide over no drug treatment in patients with IBS diarrhea. Again, there's very low quality evidence that does suggest a benefit. However, there is a large body of indirect evidence from a variety of other settings showing that the efficacy of loperamide in reducing stool frequency with minimal adverse events. Of course, it's over-the-counter, low cost, though not explicitly considered. So now we're going to move to the antidepressants, and antidepressants can work in different ways. It has a central effect and a peripheral effect. So you can use the benefit of the antidepressant effect for mood if that can negatively impact the coping or management of symptoms. They also are thought to have a visceral analgesic effect by working on the brain-gut pathways, specifically by enhancing the pain inhibitory pathways, and also can alter motility. The tricyclic antidepressants will actually slow colonic motility, so often they're used in patients with IBS with diarrhea. The SSRIs tend to speed it up, although it may be transient, so it has differing effects on GI motility.
So this is the totality of evidence looking at tricyclic antidepressants in patients with IBS. And here our critical outcome was global relief response, and we also then looked at specifically abdominal pain response. We didn't look at any other individual outcomes associated with stool consistency. Our adverse effects were, again, events that led to treatment discontinuation. So we found that there was overall improvement in adequate global relief with 202 fewer failures, and there were some note of more adverse events leading to treatment discontinuation with use of this drug. This translated into overall clinically meaningful improvement in global relief. And then looking at our individual outcome of abdominal pain, there was also clinically meaningful improvement in abdominal pain as well. The overall quality of evidence across all critical outcomes for TCAs, however, was deemed as low because there were serious methodological limitations in many of these older studies with significant variations in doses that were used in populations that were studied, which led to us rating down from high quality evidence to low quality evidence.
So one important point to make is that the effect by tricyclics on IBS symptoms is independent of effects on depression. Typically, in clinical practice, we use doses between 10 and 50 milligrams. Many of the trials used higher doses, which were the doses used in the, quote, older days. For depression and anxiety, we often used 100 or 150 milligrams than we really use in clinical practice right now. So that's one thing to take into account when you look at this data. The overall quality of evidence across all critical outcomes for tricyclics was low. They should be used with caution in patients at risk for prolongation of the QT interval. In some patients, there's mild sedation that could be a benefit. Many of the IBS patients, particularly ones with more severe symptoms, have insomnia or poor sleep, and we know that poor sleep is associated with worsening bowel symptoms. So to improve their sleep and mood can be beneficial in the overall management of IBS. However, if a patient doesn't want the side effect, then you try to use a tricyclic with less of that effect. So should TCAs be used in patients with IBS? The AGA gave it a conditional recommendation with low quality evidence, suggests that TCAs over no drug treatment was suggested in patients with IBS with diarrhea. In particular, just because it has an anticholinergic effect. Overall improvement with limited downsides, low-cost option.
So this is getting at our next antidepressant class of medications. Our PICO question here was, should SSRIs be used in patients with IBS? Again, our critical outcome is looking at global relief response. Next slide. And we found that there was actually no improvement in global relief symptoms with the use of SSRIs, and adverse events, unfortunately, were not reported in these randomized control trials that I looked at. So overall, there was no clinically meaningful improvement in global relief. We also looked at the individual outcome of abdominal pain and found no clinically meaningful improvement in abdominal pain as well. So the overall quality of evidence across all critical outcomes for SSRIs was low, and the quality of the evidence was rated down due to issues of unexplained heterogeneity and imprecision.
So the trials did not found that the medications did not significantly improve global symptoms or abdominal pain in IBS, and the effectiveness may depend on individual characteristics of the patient. For example, if there's a coexistence of psychological symptoms, potentially SSRIs would be more beneficial, but that's something that would have to be studied. The overall quality of evidence across all critical outcomes for SSRIs was low. There was insufficient data to assess effect on individual symptoms, and there was a lack of improvement in health-related quality of life. These were small studies, but when we looked at them collectively, even though in the study it may have shown some benefit, overall it didn't. So should SSRIs be used in patients with IBS? The AGA gave it a conditional recommendation based on low quality of evidence, suggested against the use of SSRIs over no drug treatment in patients with IBS, and it doesn't have to be specifically IBS-D, it's just IBS. Overall, there is no improvement in global relief and abdominal pain in IBS and minimal adverse effects of treatment. So lastly, antispasmodics. They've been used for many years in IBS. They can work in different ways. They can cause smooth muscle relaxation by either a direct effect, and there's some examples that you can see there in the slide. They have an anticholinergic or antimuscarinic properties, and a couple of those antispasmodics are ones that we have in the United States, dicyclomine and hyoscyamine. They definitely have side effects, as you know. Dry mouth, constipation, urinary retention, visual disturbances are a few of them.
So this is looking at the body of evidence for antispasmodics in patients with IBS, and for which we had actually a number of RCTs. And again, our critical outcome here was global relief response, and unfortunately very little data on adverse events was available. Overall, there were 200 fewer failures of adequate global relief, which translated into clinically meaningful improvement in global relief. However, there's no clinically meaningful improvement in abdominal pain. The overall quality of evidence for antispasmodics was considered low. This is because there were serious methodological limitations in many of these older randomized control trials, and also possible risk of publication bias. And so both of these led us to rate down the evidence to low.
So the aspect of antispasmodics that make them ideal for potentially IBS is that they reduce colonic smooth muscle spasms. There's 12 different agents in 22 randomized clinical trials. There are a lot of variability. In the United States, hyoscyamine, dicyclomine, and peppermint oil are the ones that are used for IBS. And the reported data was really based on continuous use and not as on needed or as needed basis, which many patients will use. The clinically meaningful benefit for global relief was seen. There's some improvement in abdominal pain, but not clinically meaningful. Often in clinical practice, we use it on a as I said, as needed basis episodically, and usually for postprandial symptoms. If it's taken 30 minutes before meals, it can, just by anecdotal, and a lot of experts in the field have noticed that it can reduce postprandial symptoms, and its use is limited by side effects, and that's another reason to use it as needed as opposed to continuous use. So should antispasmodics be used in patients with IBS? The AGA gave it a conditional recommendation based on low-quality evidence, suggests that antispasmodics over no drug treatment in patients with IBS. There's overall low quality of evidence, but studies showed modest improvement in abdominal pain symptoms with minimal risk of important adverse events. Did you want to go over this, Shotzi?
Yep, so this is a summary of our recommendations in our guidance document. So on the left, you'll see the pharmacological agents, and then on the right, you'll see the strength of recommendation as well as the quality of evidence. So for linaclotide, AGA made a strong recommendation for its use based on high-quality evidence. For lubiprostone, the AGA suggested its use, so a conditional recommendation for its use was made based on moderate quality evidence. And for PEG laxatives, again, the AGA made a conditional recommendation for its use based on moderate quality evidence. Moving on to the next class of agents, so we looked at rifaximin for IBS-D patients, and the AGA makes a conditional recommendation for its use based on moderate quality evidence. For Alosetron, the AGA makes a conditional recommendation for its use based on moderate quality evidence. And then for Loperamide, also the AGA makes a conditional recommendation for its use based on, unfortunately, very low quality evidence, however. So looking at our class of antidepressants and antispasmodics for IBS in general, the AGA makes a conditional recommendation for TCAs based on low quality evidence. However, the AGA makes a conditional recommendation against SSRIs, again, based on low-quality evidence. And finally, antispasmodics, the AGA makes a conditional recommendation for its use based on low-quality evidence.
So please note that this technical review and the guidelines are available in the November issue of Gastroenterology and can be found on the journal's website at www.gastrojournal.org. And both manuscripts can be accessed from the AGA website as well at www.gastro.org/guidelines. Now, we still have a few minutes to take some questions. As a reminder, if you have a question, please type it in the question pane and it will be answered in turn. If we can't get to all the questions, we'll post a Q&A online.
All right, thank you so much, Dr. Chang and Dr. Sultan. My name is Madeline, and I work here at the AGA with guideline development. So I'm going to be relaying the questions to you, just like Dr. Chang said. You can enter them into the window pane, and we will get them to our presenters here. So the first one we have is, what questions do I need to ask a patient to determine which medication would be best for them? Or are there any medications you would recommend starting them on?
Well, it would be based on the IBS bowel habit subtype. So you would want to first determine they have IBS by the criteria I mentioned, the association of pain and altered bowel habits, and then you want to determine what type of bowel habit subtype they have. Since some treatments, since they affect bowel habit, you want to use it in the correct patients. And then after that, you would probably want to determine how severe their symptoms are. Is it something that is more frequent that they would need an ongoing treatment, or could they potentially have as-need treatment? Whether diet is a problem because they have post-meal symptoms, and might be something, even though that we didn't assess, but something that I think would be good to assess in patients, and many patients are very willing to have a dietary intervention. You want to make sure that there's no what we call alarm signs or red flags to determine that there might be something other than IBS. And then you, of course, want to know what treatments they've been on before, what they're interested in taking, and then you would go according to that step process of, if it's IBS-C, the things to consider are, laxatives, recognizing that it may not help abdominal pain as much, Lubiprostone, linaclotide. If you've already passed, fiber, for example, which is usually a first-line treatment, and then you do the same thing with IBS with diarrhea. I don't know if you had a specific question. If you do, you could type it in. I just gave you a general response.
Thank you. We have another one here. The question is, what tricyclic antidepressants have lower sedation and tiredness side effects in your experience? And also, what would be the typical starting dose for these?
Yeah, the typical ones that are used of tricyclics for IBS would be nortriptyline, desipramine, and amitriptyline. Nortriptyline and desipramine are less sedating. So they don't have as much activity on the histamine receptors. They are less anticholinergic activity, even though they have some. So they tend to be less sedating, and they're less constipating, even though they can do both. But amitriptyline is definitely the one that can slow the gut transit more and also be more sedating. So if you don't want the sedation effect, you would use desipramine or nortriptyline. I tend to use desipramine more just because there's more data with it. I start at 10 milligrams at bedtime, and I raise it by 10 milligrams up to the lowest, most effective dose. I usually don't go above 50 milligrams, but that's variable. But some people like Dr. Drossman, who used tricyclics in IBS before everyone else did, and is really the guru on that. He starts at 25 milligrams because he wants the patient to have some symptomatic benefit. My issue with that is if patients tend to have side effects to drugs, or they're a little hesitant, I put them on the lower dose, recognizing and telling them that they may not have a symptom benefit right away, but I just want to make sure they tolerate it, and then they tend to get used to it, and then I raise the dose. But if a patient has a side effect from tricyclics, they usually need to be on it for a couple weeks, and then they can raise the dose. So you just want to balance the beneficial effect and then minimize the adverse effect. And the other thing to remember, it may alter bowel habits early, but the effect on pain may take 6 to 8 weeks, and then you want to get at the appropriate dose.
All right, thank you. So going along with that question, we also want to know how long of a period should I give to see if a patient responds to new medication. Obviously, some medications might be different from others, but what's the general window?
Yeah, that depends on the type of medication. If you look at a medication like, let's take IBS-C, PEG, linaclotide, Lubiprostone, they can see effects in the first day to 2 days. And in fact, with linaclotide and Lubiprostone, they actually measured the percent of patients of the time that they would have their first bowel movement. So most of them will have it within 48 hours, and many of them will have it in the first day. So you're going to know the effect. In fact, when I put patients on medications like that, I make sure that they're at home or a place that just in case they're going to have a bowel movement that's a little more urgent, or even diarrhea, that they stay near home or near a bathroom. Then you have other medications, and of course Loperamide would work just as fast, and also Antispasmodics, but of course you want to take it before a meal. But a medication like an SSRI or tricyclic, they would take a longer period of time for the overall benefit. And I think that's really important to tell patients, is the expectation, because it's a very unpredictable condition, that they may see some initial effects, but to really see if a medication overall helps their symptoms. The FDA, for example, recommends 4 weeks at a minimum, but usually 8 to 12 weeks, because there's fluctuation in symptoms just naturally, and you really want to determine if a medication is helpful. And if you decide to start on a lower dose, which we often do in patients with IBS, they have a lot of side effects with medications, of course you're not going to really see a beneficial effect until you're at a good dose.
Thank you. So we have one more question for you. It was mentioned earlier that with drugs that can cause nausea, taking them with food might help. What can a doctor do to help ameliorate diarrhea in patients taking drugs that might have this side effect?
Yeah, what you need to do is use a lower dose. Often what I do is I just assess how their bowel habits are now. If they're an IBS patient that happens to go every day and the stool forms on the hard side, but they're going frequently, I probably, even though you may want to use the higher dose, like say of linaclotide, which is recommended by the FDA, I might start at the lower dose just to make sure that they don't get diarrhea. And if they don't have enough efficacy, then I'd move to the higher dose. But I tend to use medications at a lower dose if they have a propensity for having diarrhea, or their constipation symptoms don't sound as bad, because you can always raise it. And also what I do, if patients are already on medications with constipation, they often don't want to completely stop their medication and try a new drug. So what they like to do is you remove one of them, like say stool softeners or something else, or lower that dose while you're introducing a new one, and then you try to transition off the old one and go the new one. In that situation, I might use a lower dose while I'm trying to determine how they do. Sometimes what we do also is we don't do it every day. We'll recommend it, Monday, Wednesday, Friday, for example.
Thank you. So that's all the questions that we have.
Okay. Well, I want to thank everyone so much for joining us for this AGA webinar on the IBS treatment guideline. The recording of the session will be available on the AGA website in a few weeks. Also, if you're interested in learning more about IBS, I hope that you'll join us in August of 2015 for the Freston Conference. As you know, this is a standalone single-topic conference that the AGA puts on each year. And this coming year, in 2015, it's going to be entitled A Renaissance in the Understanding and Management of IBS. And I want you to continue to read the AGA Digest for more information about registration, which opens on February 10th. And I've been a part of organizing, and I will tell you we have top-of-the-line speakers with a breadth and depth of information. So hopefully you will join us in Chicago in August. Thank you.